Hello, my name is Fatima Loren Dreyer, Executive Director of the Health Alliance for Violence Intervention. I'm going to be sharing with you further information about the role of hospital-based violence intervention programs. So I'd like to begin by talking about violence itself. It's the leading cause of death among African American boys and men, and the second leading cause of death for Latinos. Recent estimates put the cost of violence at roughly $280 billion annually. And in the work that we do, focusing on boys and men of color, we find the phenomenon of cyclical violence in many major cities. So roughly 30 to 40% of those who go to our hospitals injured by violence are likely to be injured again within 5 years. What we also find is that roughly 80% of violence that we find in most cities are perpetrated by less than 2% of the population. Some of those estimates are less than 1%, somewhere between 0.2 and 0.3%. So we're talking about very, very small numbers. And so the large burden of violence on society actually lies within the hands of very few. And the particular challenge we face is that those few are hard to reach. These are not young people who participate in, the local basketball games, right, that are sponsored by the YMCA. They're hard to reach. They're well-connected network, but they are challenging to reach. And some of the most sophisticated community violence intervention strategies that we have and that have been deployed in cities focus specifically on this population, this hard to reach population. And you may have heard of some of these interventions: street outreach, peace fellowships, gun violence reduction strategy, hospital-based violence intervention. What we all have in common is that we focus on this hard to reach population. And advancements in the field really encourage us to focus on an ecosystem, really supporting this hard to reach population through a range of access points. And what we've seen in cities that deploy this ecosystem a level of intervention, we see significant reductions. For example, in Oakland, we've seen 50% reductions in violence that have been attributed to these interventions over a 9-year period, as research by a number of reputable researchers at universities. I'll talk specifically about Oakland to give you a sense of the size and the magnitude of these interventions, right? So we have a city that has over 400,000 people. The criminal justice population being roughly 20,000, but those who are at very high risk, very small, right? 250 to 350 people. And as I said again, the ecosystem that we're supporting has these particular attributes. Again, they identify those who are at very high risk. They are those who've been, again, either violently injured or perhaps a close peer or family member. They're part of that network. We leverage credible messengers who have lived experience and high level of credibility among those high-risk clients, many of whom are directly impacted, and I'll talk about them a little bit later. They provide individualized wraparound care, so intensive case management, some call it life coaching, and then monitor progress over time, right? There's kind of a doors always open policy, and we work to understand the needs of our clients and work to transform systems. So this is what we would promote as a community violence intervention ecosystem. These are some of the core components of them. And here's just another slide that highlights some of the interventions that comprise that ecosystem. Of which hospital-based violence intervention is one such strategy. So important to name here that we, shifting now from talking about an ecosystem to our particular work supporting hospital-based violence intervention across the country. And that's where the Health Alliance for Violence Intervention comes in. We were founded over 10 years ago. We currently serve over 85 cities build hospital-based and hospital-linked programs in the United States and beyond. And we do so through a range of strategies. We support, again, training and technical assistance for hospitals and health systems that want to implement the model, build those partnerships with communities. We help encourage model fidelity through a membership. So those programs that have achieved a certain level of program implementation, they've served a certain number of clients and have done so through sound model fidelity, can then apply to become members of our organization and sustain that membership. They complete an annual survey, so we continue to monitor their progress and their client base in the field. We also convene an annual conference, convening over 100 cities across the United States and progressively Europe and Latin America to talk about and share best practices in the field. And this is a photo from our conference. It's quite known. It's one of the largest in the field. So I'm going to talk a little bit more about the model, and we begin with a discussion about rates of repeat violent injury. So we are, this is a kind of a chart that looks at some of the data over the years about repeat re-injury rates within hospitals. So they range quite significantly. See on the high end, 62% of those who have been violently injured return with another violent injury. But we say generally rates of re-injury sit at roughly 30 to 40%. Our model begins with the violent injury. When patients are in the hospital, again, they're part of this high-risk group because they have been violently injured. They, of course, receive care within the hospital, attending to those physical wounds. But our work also encourages addressing the social determinants of health, and doing so not only beginning that conversation in the hospital, but post-discharge, and thinking about, and as you see on the left, a range of opportunities for further support, housing, looking at safety planning, addressing things like retaliatory violence and crisis support, job placement, legal advocacy. There's a range of supports that our programs provide for this high-risk population as part of this broader ecosystem. So a little bit about the structure of these programs. Hospital-based includes staff who are employed by the hospital, right? Community partners and referral partners are certainly a part of hospital-based groups, but all the staff are employed by the hospital. Hospital-linked, many of the staff, including those credible messengers I mentioned earlier, the violence prevention specialists, are based at a community-based organization, and they actually have an MOU with the hospital, and those workers are allowed in to support patients at bedside and post-discharge. And then we have a hybrid model, not as common, but exists, in which staff are employed both by the hospital and by a community-based organization. It's important to name here that we are looking at individual violence, of course, but we recognize that violence exists within much larger systems, what we call the interacting layers of trauma. And while our work looks at the interpersonal realities of our clients, we acknowledge and participate in an analysis of the socioecological model. We want to look at community in place. We want to think about the role that healthcare, health systems, and hospitals play as systems, as institutions in structural violence, racism that can impact those who then ultimately become victims of violence further downstream. And of course, there's a broader legacy and history of structural violence that is important to attend to and acknowledge. So as we kind of enter into a discussion about some of our impacts, we acknowledge that there's a much larger forces at play in the what it takes to address violence in a particular place. So those interlocking layers of trauma are important. For an HVIP, we are looking at racial equity, we are addressing those social determinants, and thinking about continuity of care and trauma-informed care. So those are really critical. So how do they actually how do we actually deploy this analysis? Well, we begin with the role of the violence intervention specialists. As I mentioned, these are our case managers. They have lived experience that is similar to those of the clients. And so they deploy a level of credibility. They are leveraging what we call a golden moment, a golden opportunity, a teachable moment, which of course is common in other healthcare interventions, but certainly relevant here. A client who has had lived experience, has just been shot, perhaps is thinking about their own life, thinking about the lives of those around them. There are a number of concerns, and our credible messengers, our violence intervention specialists, sit at bedside and begin to think with our clients about where their concerns are, where there may be trauma, and think together as part of an interdisciplinary team about opportunities for support. So this is both happening before discharge and also after discharge for 6 to 18 months, where we see engagement. And what we find so incredible about this workforce is how effective they are. We have a number of trauma surgeons at level 1 and level 2 trauma centers who are part of our network. And our board chair, who's a trauma surgeon at UCLA, has often said, when I'm in surgery and I'm operating on a victim of violence, I think to myself, let me get this young man off the table so that we can then hand him off to our violence intervention specialists, who will then save his life. Right. So just to kind of think about the relationship as part of this interdisciplinary team. However, this particular worker, and this is important to name, it's not well funded, well supported, and part of that we see is a problem of sustainable funding, and we've addressed that by the HAVI was instrumental in providing a taxonomic code through the Uniform Claims Committee for this particular workforce. And we've now working and advocating for this to be reimbursed through Medicaid, which is the primary source of healthcare for our patient population. So I'll share a little bit more about that later. A little bit about the structure of our staff. There's often a medical director or medical professional who helps to champion this within the hospital. We have program director who helps supervise both the intervention and case managers. You see them on the left. Their caseload is roughly 15 to 25 clients. We've got a clinical supervisor that supports these typically licensed clinician that will support the social work, the care, and there may be in larger programs additional clinical staff that support clients, and then some sort of administrator that helps manage data and looks at kind of evaluation and assessment considerations. And as I mentioned, the way this structure, this org structure is configured within the hospital or within a CBO will constitute whether it's called a hospital-based, hospital-linked, or hybrid program. So a little bit about kind of our process. As I mentioned, we have a gunshot wound victim or stabbing, a number of other violent victimizations. They enter the hospital. They're admitted, and there are, of course, many of the consequences of trauma that are important to attend to: the physical wounds, the emotional wounds. And our intervention meets clients where they are through psychoeducation, intensive case management, therapy, advocacy, and help them in achieving their goals of safety, thinking about their healthcare, managing grief, education, finding stable employment and stable housing, really addressing some of those social determinants. So I'll talk now about the impact of these programs. Unfortunately, and many of you know this, that the field of violence prevention has had a real dearth of investment in research over the years. That's beginning to change. But we were proud to say that we've enjoyed some randomized controlled trials for our work, and some of the, we have materials to follow that summarize some of the key findings of these randomized controlled trials. Is for the adult population. There are a few for the pediatric population. But suffice to say that we've seen a meaningful reductions in violent re-victimization, violent re-injury as a result of participation within these programs. One of the most cited studies is out of Baltimore, and the researcher, Dr. Carnell Cooper, actually sits on our board, found that patients were 4 times less likely to be convicted of a violent crime, representing a savings of $1.25 million in incarceration costs, and 4 times more likely to be employed at program completion. There's also, again, I mentioned the pediatric populations. There's a Chicago RCT that focuses on young people, and you see the comparison group. We see reductions in violent re-injury. So, very important work that's happening, but I thought it would be important to end with a discussion about some of the things that are happening nationally. I'm proud to be a part of a broader coalition of community violence intervention work, strategy, and advocacy that's worked closely with the federal government on securing a $5 billion investment in community violence intervention. In your materials, you'll see a recent op-ed that I penned for the Washington Post that talks more about the models and how they work together. But I think important to name here that we've advocated for CMS to issue guidance related to violence prevention professionals being reimbursable by Medicaid. And we're pleased to say that CMS recently organized a webinar sharing with state authorities that this is indeed the case, and answering questions that state authorities have about this work. And so we are now in a position to advocate at a state level for violence prevention professionals, again, those credible messengers, that really vital workforce to be reimbursed. So there's quite a bit of work happening. It's all incredibly exciting. But I want to, I think my final note and impassioned plea is that this is, I think, an especially important opportunity for philanthropy to get involved. Federal dollars certainly contribute. A $5 billion investment over an 8-year period is certainly big. It's certainly, we're not done yet. We've not won this yet. The infrastructure bill will need to be passed. However, we do think that philanthropic support for this work at this stage could help programs locally and nationally leverage these federal dollars, because the time it will take for programs, the level of technical assistance individual cities will need to be prepared to apply for these funds, that's what's upon us right now. And as a technical assistance provider, we are getting calls from cities across the country who are interested in starting programs and need seed support, need support for training, and so beginning to deploy a national infrastructure is upon us right now in anticipation for these federal funds. So we're really at an exciting moment. I look forward to connecting with all of you. I believe my materials and information are attached to this presentation. Thank you so much for the opportunity, and take care.